Everyone, my name is Linda Johnston and I am the Dean and a Professor at the Lawrence S. Bloomberg Faculty of Nursing at the University of Toronto. I'm also a member of CASN's Research and Scholarship Committee, and it's with great pleasure that I welcome all of you to the February session of the 2019-2020 Lunch and Learn series. I'm sure many of us are familiar with the concept of the Lunch and Learn, where faculty members come together during their lunch hour to share with one another projects they are working on and to dialogue and discuss methodologies, successes and challenges they encountered in their work. This webinar series is intended to serve as inspiration and a networking opportunity for participants while recreating the collegial feel of the Lunch and Learn. This year, each Lunch and Learn session is highlighting one of CASN's national research priorities for nursing as a theme. Today, for the fifth session of the 2019-2020 series, the theme is Nursing Research Priority Number 5, Roles, Scopes of Practice and Value of RNs and or NPs to Healthcare. And we will hear from Dr. Ruth Martin-Meisner and Dr. Andrea CASN. Dr. Ruth Martin-Meisner is a professor and the director of the School of Nursing and Assistant Dean Research, Faculty of Health at Dalhousie University, Nova Scotia, Canada. She is an affiliate scientist with the Nova Scotia Health Authority and the Maritime Spores Support Unit and co-director of the Canadian Centre for Advanced Practice Nursing Research at McMaster University. The focus of her research is evaluation of the implementation and outcomes of the nurse practitioner role and innovative interprofessional team-based models in primary and long-term care, mainly in Canada. It has been widely used to inform policy, and she is a recognised knowledge broker for key stakeholders and decision makers provincially and nationally. Dr. Andrea CASN is a postdoctoral fellow at the School of Nursing, Dalhousie University. She received her PhD in Public Health Science from the University of Toronto in November 2019. Andrea's research uses critical social theories and qualitative methodologies to understand and improve individuals' experiences with reproductive health services in Canada. During today's webinar, titled The Evolving Landscape of Nurse Practitioner Scope of Practice, Putting a Spotlight on Medical Abortion, Drs. Martin-Meisner and CASN will discuss how the nurse practitioner scope of practice is evolving to meet the health needs of people. This presentation will review contemporary understandings of scope of practice and trends in the evolution of NP scope of practice in Canada. Drs. Martin-Meisner and CASN will provide an introduction of medical abortion in Canada and the implementation of changes to nurse practitioner scope of practice. The Canadian NP mifepristone implementation study will also be described along with findings from a meeting held in the fall of 2019 with nurse practitioners, nurses and other stakeholders from across Canada to discuss research priorities for nursing roles in medical abortion care. After the presentation, we'll have time for questions. To submit a question, please use the question and answer function on your screen. Once you have finished typing your question, please don't forget to hit send. I'll now turn the session over to Dr. Martin-Meisner and Dr. CASN so we can begin.
Thank you very much, Dr. Johnston. I pressed the button prematurely. Dr. Carson and I are very happy to be here and have the opportunity to speak about this important topic. So we are going to share the presentation. We'll be going back and forth on the topic of the evolving landscape of nurse practitioner scope of practice. So I want to begin by just showing you all of the various partners that are involved in the CART mifepristone medical abortion study and the CART study previous to the NP study, because we will be getting to that later on in the presentation, but it's always helpful to acknowledge who all of the partners are in developing and implementing this important research project. So how we thought we'd organize this is starting by just talking a bit about the evolution of NP scope of practice, and then talking about medical abortion in Canada specifically, and then moving into sharing some of the methods and findings from 3 different research opportunities: the CART-mifepristone study, the CART-NP-MIFI study, and the research planning day that we held in September of last year. And then just concluding with some next steps and letting folks online know about some upcoming related research. We hope and are trying to plan our presentation so that there will be 15 or 20 minutes at the end of this for some dialogue, questions and answers and that kind of thing. Okay. So I wanted to start by just sort of reminding all of us that nurse practitioners in Canada really have now been legally recognized, at least in some provinces, for almost 25 years. So this map of Canada just shows when the various provinces and territories came on board with their legislation and regulation for nurse practitioners within the Canadian healthcare system. So 25 years is a long time, and now even for the Yukon, which is the newest territory to have legislation, that is now already 8 years since that's happened. So there's Canada's seen a lot of evolution in that time period within provinces and within the country as a whole. When we think about the nurse practitioner workforce, it's for those nurse practitioners who are joining us today who are younger and or newer to the role, may not really appreciate just how much change the last 25 years has seen. But we've come a long way in terms of establishing a standard of education and harmonization of regulation that probably those of us who were there at the beginning wouldn't have even have dreamed was possible in this period of time. But we're now up to almost, according to the CAI stats released last year, almost 6,000 NPs in the country. And when you look at the growth in NPs from 2017 to 2018, which these stats reflect, that represents an 8% growth in the workforce, which means that NPs are the fastest growing nursing workforce in Canada. So we're talking today about scope of practice. And when we think about scope of practice within nursing and within any discipline for that matter, what we're talking about really are the activities that nurses are authorized, educated, and competent to perform. And within that concept of scope of practice, there are at least 4 different levels that influence scope of practice. In legislation and regulation represents the outer boundary pardon me, of what constitutes a setting of the limits of what nurse practitioners are able, from a legal standpoint, to perform. The professional level is all of our nursing regulatory bodies and the standards and guidelines, policies, ethical standards that they set. That is another defining boundary of our scope of practice. Employers then also have the right and responsibility to identify what scope of practice within their organization nurse practitioners may have. And that may be exactly the same as what's legally defined, but it may not. There may be some restrictions that they impose. And then lastly, there's the individual level. So, and we're all familiar with this, that an individual has decisions to make about their own competence, and that's shaped by their education and their experience, and also by the needs of clients, our people that we serve. And within the context of Canada, probably one of the most important defining features of the needs of the population that we serve is what our geography actually leaves us. Sort of there's no, what am I trying to say? The geography of Canada dictates a certain degree of flexibility in the scope of practice of nurse practitioners. When you think about Canada, it's a huge country from a geographic landmass perspective. We're about 25 times bigger than the state of California. And yet within our country, we only have about 1.5 million less people than what the whole state of California has. So we're a huge country with a geographically dispersed population. And when you look at this map, it's very clear that the concentration of Canada's population is just north of the U.S. border. So we have a lot of people living in a lot of geographically dispersed land, and that has had historically and continues today to influence the scope of practice of nurses, registered nurses, licensed practical nurses, and nurse practitioners. When we think about some of the newer understandings that are beginning to shape what we know about scope of practice, is there's an increasing realization of the importance of focusing on population needs. And depending on where you are practicing, that could be the population of your primary care practice, or the population within the unit within a hospital that where you're providing services. But there is a focus on trying to understand how can we use the scope of practice of everyone to improve our ability as a healthcare system to meet the needs of as many people as possible, with a particular focus on trying to improve equity. So that's led us to an understanding of this notion of full scope of practice, or another way of saying that is practicing to the top of one's license, versus optimized scope of practice. And so what that really means is really in the context of team-based care, which Canada is moving towards as a country. It means that within each team, it's important to look at every team member's role, what might be the maximum of their license, but looking at that within the context of the needs of the population of that practice, and making deliberate decisions about who does what in order to best meet the needs of as many people as possible, especially those whose needs have gone unmet for a long time. The third point on here is one that sometimes makes some people uncomfortable, but it is the reality, and it's an exciting reality, I think, is this notion of the impermanence of scope of practice, and our need as healthcare providers to get used to this and comfortable with the reality that scope of practice is not fixed, and that it's not only nurse practitioner scope of practice that is not fixed, it's the scope of practice of those around us, other disciplines, other professionals. And within our own discipline, various provinces now are introducing RN prescribing. So that introduces an opportunity for nurse practitioners to work with those RNs who are prescribers to further use an optimized scope of practice to better meet the needs of the population. What we know from our neighbors to the south of us, the United States, which we often think, oh, the United States has, nurse practitioners have so much broader scope of practice. In reality, some of them do. Some of them have a broad scope of practice like we do in Canada, but many states in the United States actually have quite a lot of restrictions. And what that has enabled them to do is some very good and informative comparative research between states that have sort of a broader scope of practice for NPs versus those that don't. And that research is showing that the states with a broader scope of practice where nurse practitioners have improved outcomes for their patient populations, but having the legal authority for that broad scope of practice is insufficient for full implementation of these broader roles for NPs. So those other layers that I spoke of earlier are also important to attend to. Whoops, did I just go past one? Oh. One more slide for me. But I just want to note, which I'm sure all of you who are online are well aware of, the federal restrictions that have severely limited nurse practitioner practice over the last 20 years are gradually being removed. And there's very few that remain. So nurse practitioners now, as you know, participate in medical assistance in dying. They order prescribed drugs, controlled drugs and substances. They can certify people for various benefits and sign various federal forms that they previously were unable to do. And one of the restrictions that has recently been removed is the ability to provide medical abortion. And we wanted to talk about medical abortion today as an example, put the spotlight on it as a new, fairly new anyway, a new service that nurse practitioners provide, and to take a closer look at it and its implementation and how we can improve implementation of medical abortion in Canada. So I'm going to turn it over to Andy now. Oops, Dr. Carson.
That's okay. Hi, everyone. I will now provide a quick overview of medical abortion in Canada. Mifepristone is the Canadian brand name for the combination of two medications, mifepristone and misoprostol, used to end a pregnancy. Mifepristone was approved in Canada in 2015, and there were some delays in implementation, however, and it became available on January 10th, 2017. The right to abortion is enshrined in the Canada Health Act. There were some initial restrictions to access to medical abortion in Canada. For example, prescribers had to be physicians. They had to dispense directly to the patient. Mandatory training was required for prescribers and dispensers, and prescribers had to register with the manufacturer. Further restrictions included, Mifepristone could be prescribed up to 7 weeks or 49 days from the first day of a patient's last period. Ultrasound was required to rule out ectopic pregnancy and confirm gestational age. A prescriber had to observe the patient swallowing mifepristone. There was a mandatory written patient consent and information sheet, and there needed to be access to 24-hour emergency care. Lastly, follow-up was required 7 to 14 days after administering Mifepristone. On November 7, 2017, all federal restrictions related to mifepristone were removed. Access to medical abortion in Canada has improved. Providers are no longer required to witness a patient when they take the medication. Providers' personal information cannot be shared with the manufacturer. Like any other drug, pharmacists may dispense mifepristone directly to patients. Nurse practitioners, or NPs, may dispense mifepristone in multiple provinces and territories. There is universal coverage for mifepristone across the provinces and territories, with some differences in funding implementation. So for example, in New Brunswick, provincial insurance only covers abortions performed in hospitals. And training is not required to prescribe or dispense mifepristone, although there are multiple training resources and online modules that providers can take and are encouraged to take, which we will include at the end of the presentation for you if you are interested in pursuing those and learning more about them.
So the NP medical abortion study actually was developed and sort of built on an earlier study that was funded through CIHR and was focused on implementation of medical abortion from 2016 on, and its focus was on physicians and pharmacists, physicians being the only provider at the time who were authorized to prescribe medical abortion, or MIFI, and pharmacists for dispensing MIFI. And Dr. Wendy Norman from the University of British Columbia, BC Women's Hospital, was the PI for that study, and she is a co-PI on the NP medical abortion study as well. But the acronym for that initial study was CART, and it stood for the Contraception and Abortion Research Team. And it too, that team was huge and represented knowledge users, meaning stakeholders from decision-making organizations. And you can see some of them listed here. Senior researchers from a number of different universities in different provinces, some early career researchers, and some trainees and staff. So one of the features of that first CART MIFI study was the development of a collaborative interactive web platform that still is ongoing today. It was developed for that first CIHR-funded study. And this interactive web platform is called CAPS. Some of you may actually already be members of CAPS, and if not, we're encouraging you to at least try it out. You may be interested in becoming a member. It really was it's a website, a community of practice that brought physicians and pharmacists together from across the country to have dialogue. I think I touched that too fast. Okay. And I'm just going to show you a couple of things that interactive web platform offers. So as pharmacists registered on the platform, they were invited to give their location. And so I don't think this map is completely up to date, but it provided an opportunity for pharmacists to identify if they were a MIFI, if their facility, their pharmacy was a MIFI dispenser. So that enabled some building of this community of practice across the country and helped pharmacists identify and physicians to identify whether there was a local pharmacist who might be dispensing the drug. The platform also provided an opportunity to actually ask questions of the people who were providing, and you didn't have to be a provider to join, but most of these, I think all of these people were providers of medical abortion, and they would ask questions in order to get feedback from practitioners who were prescribing MIPI. These would have been early adopters of the practice. And this is one of the questions that, as Dr. Carson indicated, when MIPI first became available, training was mandatory for physicians and pharmacists in order to prescribe and dispense. And so this was a question asked on the CART platform, and you can see what the response was. And these kinds of questions that were providing real-time answers to policy questions really influenced the decision makers at Health Canada in order to make the subsequent decisions they did make surrounding some of the restrictions on MIPI prescription. So these various pop quizzes would become available and are still being made available on the CAPS website. And part of the CAPS website, there will be a new page being developed for NPs, although NPs are free to join the CAPS website. But again, it's real-time responses to what the members are thinking or doing in relation to medical abortion. And this just shows you who the members are as of January 2020. And you can see, well, I hope you can see, the yellow line is nurse practitioners in the country. And you can see that the slope of that line is going up, so the number of nurse practitioners is increasing. But you can really see that the CAPS website and the community of practice has really had an impact, particularly on physicians. The other really cool feature of this web community of practice is people can ask questions of each other, so clinical questions that they have from day to day, and get advice from their members. All of the questions are screened by Dr. Norman. So there's no opportunity for anything weird to get passed along. And this is just a graph of the NP distribution by province, and you can see, although the numbers are still relatively small, just a little over 100 NPs across the country, most of those that are participating are from Ontario or BC, but there is participation from most of the other provinces, a few NPs in most of the other provinces. The CART study included a survey about mifepristone provision by physicians and pharmacists, and that survey is now finished. And you can see that the response rate, which included CAPS members and as well as some strategies to reach other providers, had actually a fairly good response. What they found when the CART study, neither Dr. Carson or I was really involved in this initial study, but we've heard lots about it, is there's certainly a higher proportion. When you look at the rural and urban physicians who participated in this, a higher proportion of folks in rural settings are participating.
Yep. So I will now discuss the CART Nurse Practitioner Mifepristone Implementation Study, or as we call it, CART NP-MIFI. And this study is a collaboration between CART, so the Contraception and Abortion Research Team, University of British Columbia, Dalhousie University, and several knowledge user partners. And it is funded by the Canadian Institutes of Health Research. Our co-principal investigators are Dr. Wendy B. Norman at UBC and Dr. Ruth Martin Meisner at Dalhousie, who's beside me today. And the research question asks, what are the barriers and enablers to the successful implementation of NP-provided medical abortion in Canada? And a key priority for the team is better implementation and access to abortion across Canada, and specifically for marginalized and rural or remote communities. And we will focus on provincial differences and comparisons between various clinical settings in which providers are practicing. Included here are the names of our co-investigators and the provinces which they are based. So you can see it's a cross-provincial national effort. The study uses multiple methods, which include 2 surveys, one at baseline and a follow-up survey in 1 year. Semi-structured interviews with nurse practitioners, and that will occur at about 3 months' time, and a follow-up interview in 1 year. Semi-structured interviews will also be conducted with stakeholders at baseline. Participants will include, 1, NPs in Canada who are providing medical abortion. And we also want to emphasize that we will be seeking participants and NPs who are not currently providing medical abortion in their practice. Secondly, stakeholders will also be participating, and stakeholders will be those involved in policy, advocacy, and health administration. And qualitative analysis will be guided by a critical feminist lens. So this will allow for the thoughtful exploration of the socio-political context of medical abortion in Canada, with a focus on social expectations and values, and clinical relationships and interactions that affect implementation of NP provision of medical abortion. Dr. Martin Meisner and myself also wish to highlight the Research and Planning Day that was organized by members of CART, entitled Optimizing the Nurse Role in Abortion Care. And this was held on September 14th, 2019 at Women's College Hospital in Toronto, in the pink cube there. The aim of this day was to identify key priorities to support optimization of registered nurses' scope of practice in the provision of high-quality medical abortion. And this meeting was supported by a CIHR meeting grant. Attendees included 9 nurse practitioners, 4 registered nurses, and 9 members of the research team. Providers joined in person or virtually and came from BC, Ontario, and PEI. And they worked in various settings that included hospitals, women's health clinics, and primary care settings. And providers who attended were located both rurally and in larger cities. So included in the schedule was a combination of presentations by research team members, knowledge users, and NPs. And we also had networking and discussions on priority setting. So this is just our agenda. So I will now summarize a few key insights from the Research and Planning Day. First, attendees discussed some misinformation amongst providers when it came to MIPI-MISO regulations. In an example, a pharmacist requires proof that a physician counseled a patient before dispensing MIPI, which was not a current regulation. Second, successful implementation of medical abortion in nurse practice is about more than approving a new medication. And attendees discussed coordinating and communicating with pharmacies regarding stock and arranging access to an ultrasound machine if none were on site. Third, it is important for nurse practitioners of medical abortion that this service be demystified in primary care, and they emphasize that any physician or NP can offer it. Fourth, NPs frequently lose medical abortion patients to follow-up, and this is a concern because of patient safety and also potential implications for providers if follow-up does not occur. And some attendees discussed and were exploring solutions to this issue via telemedicine. Fifth, medical abortion training, mentorship, and resource sharing are important for provider confidence to prescribe medical abortion and for better patient experiences. Lastly, attendees were interested in making medical abortion more accessible to users, for example, by mitigating barriers for marginalized groups or offering patient-friendly resources. So I will now discuss the next steps for the CART-NP-MIFI study. The target for the baseline NP medical abortion survey is March 2020. This will be followed by qualitative interviews with NPs, both those who provide and are not currently providing medical abortion in their practice. We will continue to interview stakeholders. In approximately 1 year's time, the second follow-up survey will then occur, as well as follow-up interviews with NPs. So if you have any questions or would like further information about participating, you may reach us at cart.np@dal.ca, which we've included at the bottom of the slide there.
Okay, I just want to tell you about two other studies, Canadian studies, that are going on, about to launch, related to medical abortion, and which nurse practitioners can participate in. So one is the Canadian Abortion Providers Survey, and we want to be clear that the survey that Dr. Carson just spoke about, the NP-MIFI survey, that is a unique survey about nurse practitioner practice of medical abortion, whereas the Canadian Abortion Provider Survey is a different survey, and also NPs are welcome and encouraged to participate in, but it asks different questions. So we're hoping that through this webinar and other strategies that we're using that we're not going to confuse people. But this Canadian Abortion Provider Survey, being led by Dr. Regina Renner from UBC and Dr. Marnie Follier-Wagner from the University of Montreal, and Dr. Norman is also a co-PI on that. This is a repeat of a survey, abortion provider survey that was completed in 2012. And so it's a national survey to try to understand abortion provision, abortion of all types, not only medical abortion, across the country. So its aim is really to better understand the workforce, and that includes anyone who is participating in the provision of abortion. So nurse practitioners, nurses, physicians, and midwives. And obviously that means that they're not necessarily independently providing abortion. Some of them may be doing so using some sort of a delegation. But it focuses on abortion provision and including the services, the types of abortion, the methods being used to perform abortion, stigma, and resilience. So really important survey and another really important opportunity for both nurse practitioner and registered nurse participation. The NP-MIFI survey is expected to be launching in March, and this one, the Canadian Abortion Provider Survey, will be a bit later. We are coordinating with Drs. Renner and Wagner to try to not confuse people or put too much of a response burden on potential participants. The other really exciting study that has just recently, like really hot off the press, been funded by CIHR is an abortion outcome study. And I'm sorry, I don't have the information down here about who the PIs are, but we can look that up for you. But I just wanted to let you know about it because it really is an important study that will identify the outcomes of abortion using administrative data in British Columbia and Ontario. Those are two provinces that have the admin databases that are needed in order to do this study. And the outcomes that they will be looking at are access, adverse events, and cost. So that brings us to the end of our formal presentation, leaving us 15 to 20 minutes for some questions and comments. This last slide that you see is a list of resources that you can access regarding medical abortion in particular. There's different training opportunities that are available. And we have also included publications from the CART-MIFI study and some references from our presentation. So Julia,
thank you.
Or Linda?
Yeah, thank you, Ruth and Andrea. While we're waiting for people to submit questions, if I can just ask you a couple of questions myself. I see Wendy's been on there posting to just ensure people are aware of the difference between the CAP survey and your CART-NP survey, Ruth and Andrea. Could you just talk a little bit more about the marginalised populations and recognising the difficulties and the sensitivities and ethics challenges? Do you see having individuals from those populations as stakeholders in your project, or that's a challenge?
Do you mean in the NP-MIFI study?
Yeah, yeah.
Just so I'm clear, you're asking whether the clients themselves,
yes,
women, would be participants in terms of being a stakeholder?
Yes.
That's a very good question. We did spend quite a bit of time talking about this in the September meeting because the people that were there, the NPs in particular who were around the table, all of them really talked about the diversity of women that they were seeing in their practice, and many were from equity-seeking groups, marginalized populations of various sorts. We haven't talked about that in terms of actually including them in terms of a target group to actually get information from in the NP-MIFI study, but it's a really good point and something that we should think about more. But we haven't. Wasn't part of our design up front.
Right. Just checking to see if there's any other questions on your mind. Any questions or comments? Feel free to put them through. If I can just ask another question while we're waiting for people to type, and I suppose, Andrea, maybe this is for you. If you could talk a little bit more about the critical feminist lens framework that you intend to use in undertaking the analysis of the qualitative data?
Mm-hmm. Yeah, so we thought that was a really interesting addition to the qualitative part of the project. Because abortion is still, I would argue, contested even in Canada, and there's a lot of socio-political issues around it. It's typically been a women's health issue, although not everyone who seeks abortion identifies as female. And so we really wanted to bring that lens to things and thought it would really enhance it. And the focus specifically would be not only systematic forms of power and structural issues of power that are happening, but you know, at a really day-to-day interaction and relationship level, really focusing on that element of power. So, you know, in interviews, we're really going to explore that and some of these things that providers are coming across, and really being able to bring these concepts from feminism to the study. So things like identity, gender, of course, you know, power, all these different concepts that you can bring. I mean, intersectionality is one as well. That will really enhance our analysis and hopefully lead to more meaningful implementation. Yeah, so we're really excited to see where that takes us.
Thank you. Not seeing anybody. Everybody's shy for Monday by the look of it. Nobody's providing any questions or comments. One last question from me. There may be NPs and or RNs, I think you said, can participate in the research when you launch in March 2020, I think you said, Ruth. Is there an opportunity for, is there a way for people to find out about it, or how are you planning on letting people know about the launch and getting their involvement?
Yes, so that we've spent a lot of time figuring that out and coordinating with the various studies. So we are trying to recruit through the CAPS website, of course, but also Josette Roselle from the Canadian Nurses Association is a knowledge user and a co-PI on the NP mifepristone study, and she's also a co-investigator on, I think, the other two studies, and has been instrumental in connecting us with the Canadian Nurse Practitioner Association, as well as all of the nurse practitioner associations in the provinces and territories, and then through their website. So just trying to be as creative as we can. Am I forgetting? Networking, yeah. So we, that September meeting that we had in Toronto, we think of that as the beginnings of an NP medical abortion community of practice. The people that attended there weren't all NPs, but the focus was on NP and registered nurse involvement in medical abortion. And so we're reaching out through them as well. So that would be an example of the networking.
Great, thank you. And I see your co-principal investigator, Wendy, has posted a comment for other participants on this webinar as to how best they can reach, you can reach NPs who are providing or not providing medical abortion. And if participants have any suggestions, perhaps they could contact you directly, Ruth or Andrea. And Wendy's also commented, particularly interested in connecting with those who are serving populations who have difficulties in accessing timely care, or where initiating the practice has had its own barriers or challenges, or in fact been quite easy.
Yes, and we know that nurse practitioners serve populations who are underserved for whatever reason, whether that's through geography, and we are really interested in trying to include as many nurse practitioners who are providing services in rural and remote areas, but also those who are working with populations who may not necessarily be mainstream. And we know that nurse practitioners are providing really important services, and so we'd like to be sure to include them in this research.
Right, thank you. And there's the email address there, cart.np@dal.ca.
Yes.
Yeah.
Terrific.
You know, if there are no, I mean, if people online have comments too about their own experience, we're interested in hearing that as well.
And they can just contact you via that email address also?
Yes, or now if there's in the 5 or so minutes that are left, if there's anyone who wants to provide a comment about their own practice, that would be also, we'd be interested in that.
Okay, of the 17 participants who are still there, has anybody got any thoughts or comments that they'd like to provide? I hear somebody typing even as we speak. I see. Thanks, Carissa. Just a slight delay while Carissa's typing. What's happened there? The message seemed to disappear. There we go. Carissa's comment. They're introducing NP in the hospital setting. How do you start having discussions with the team about team composition and scope of practice, as this will be a major change?
I'm so glad you asked that question. I wish I had an easy answer for that. I think this is really one of my own view is that this is one of the big challenges for healthcare teams to be addressing. And it's a research opportunity as well. Is this notion of optimizing scope of practice within a team, because that is really what you're talking about, is who should be on the team in order to provide the service and who's going to do what. And, you know, I don't know that there are easy answers. I'm not aware, and maybe others are aware of any tools that could help teams with this discussion. But I do know that one thing that has been helpful more broadly, it's not specific to NP provision of mifepristone necessarily, but one thing that's been helpful and is being used in some practices in Canada and in other countries is the notion of just developing a logic model. And you will be familiar with the concept of a logic model in relation to program evaluation. And what some teams, and what, particularly when there's an introduction of a new service or a new provider is or has occurred, they're using this idea of a logic model to really work through you know, what the roles and responsibilities and activities and expected outcomes will be. So that might be one potential approach that you might want to use. I think it really does involve conversation and a level of trust and among team members, a leader who can guide that conversation to keep the conversation open, respectful, focused on the goals that the team wants to achieve, which in this case is really about you know, meeting the needs of the patient population for medical abortion or for abortion in general. It's a long answer. I'm not sure what approaches, I don't know if other people or Andrea or others want to chime in.
Oh, well, Carissa has thanked you, so made a start in helping them think through how they're going to introduce that change. So thank you very much. I'm conscious of the time, and we just seem to be, participants are dropping off slowly. So this might be the time to thank you again, both Dr. Martin Meisner and CASN, and everybody who's participated today. And just to note that the recording of this session will be made available on CASN's YouTube channel and circulated to you in the coming days. And please feel free to share the link within your networks. Thank you again, everyone, and CASN certainly hopes you will consider attending future sessions of our Lunch and Learn series. You can visit casn.ca, search for Lunch and Learn on the website for further information. So thanks again, Ruth and Andrea. Pleasure to have you in the series. We look forward to hearing perhaps a follow-up update on your research at a later point in time.
That would be great. Thank you very much for inviting us.
Thank you so much.
Thanks. Thanks, everybody.
Thanks, Linda. Thanks, Ruth and Andy, if you're still online.